Vision loss associated with wet macular degeneration is due to the growth of new blood vessels underneath the retina. These are abnormal blood vessels which tend to break and bleed, which causes the vision loss associated with wet macular degeneration. By stopping the growth of the new blood vessels or causing them to reverse or go away, we can stop the progress of the macular degeneration and sometimes even reverse the course. There are several different treatments that we have available to do this. One of these is thermal photocoagulation, where we cauterize the new blood vessels. This is an older type of therapy which is used very seldom now. A second type is photodynamic therapy, which is a cold laser. This is also something we've used over the last 5 to 7 years, but its use has declined recently because of the advent of vascular endothelial growth factor inhibitors. These are drugs that we inject into the eye that block the effect of vascular endothelial growth factor, or VEGF, and therefore stop the new blood vessels from growing. There are two different drugs that we can inject for wet macular degeneration. One is called Avastin, the other is called Lucentis. To understand the difference between these, we have to go back to the history of it a little bit. Avastin was initially approved by the FDA for colon cancer. By stopping the growth of new blood vessels in cancers, you stop the growth of the cancer. So it's been around for a long time. When that was originally approved, they didn't feel that the Avastin would cross the blood-retina barrier to get back to where it needed to work for macular degeneration, and so it wasn't tested. Instead, they made a new drug called Lucentis. Lucentis originally began trials around 2000. It became apparent quickly that this was going to be a great drug and would treat macular degeneration much more effectively than anything else that we had. However, because it was undergoing trials and wasn't being used for anything else, no retina specialists could use the drugs. We couldn't get our hands on the drug. So some guys in Florida decided to use Avastin, and they talked to patients and said, we don't know how this is going to work. It's never been studied. We do know that if we don't do something, you're going to go blind, and we think this has a reasonable chance of success. When faced with blindness, most patients will try anything, and so they said, sure, let's give it a shot. And lo and behold, it worked very, very well. That started in about 2006, and in late 2005, we started using Avastin, because that's the only thing we could get our hands on, as an off-label use, not FDA approved, to treat macular degeneration. Lucentis was not approved until mid-2006, so for about 6 to 8 months we exclusively used Avastin. Our results were excellent, the patients did much better, and we saw no increase in systemic side effects. Subsequently, Lucentis was approved by the FDA and was released. Since that time, retina specialists have used both drugs. Right now in the United States, it seems like people are using Avastin a little bit more than they are Lucentis. And the question would be, why would you use a non-FDA approved drug over Avastin over an FDA approved drug, Lucentis? And the reason is because that we've had a lot of experience with Avastin. We're very comfortable with the results and with the side effects. The big advantage of Avastin is we're only injecting it every 6 weeks, whereas with Lucentis, we're injecting every month. Each time you have an injection, that increases the risks of complications. It also increases the number of times you need to come back and see us in the office. So I think right now in the United States, a few more people are using Avastin, but Avastin and Lucentis are both being used frequently. When Avastin is used for cancer, the dosages are much, much higher than we use in the eye. Actually, they're about 400 times as great if it's used as when Avastin is used for cancer as when it's used in the eye. However, when it is used for cancer, there are some significant systemic side effects. High blood pressure, stroke, perforation of the bowel, and thromboembolic disease have been seen more frequently when people are treated with Avastin systemically for cancer in high dosages. We have not seen those sorts of side effects when we give it in very small dosages for the eye. However, most people who are in the age group that have macular degeneration are also in the age group that are more likely to have strokes with or without treatment. I can't say that I've never seen a patient on Avastin have a stroke, because I have. But I also have many patients who have not had Avastin who have also had strokes. What I can say is I have not seen a significant increase in the amount of strokes in my patients that I treat with Avastin. There is a study started now called the CAT trial, which is looking at this particular question, but the results won't be out for several years. Both drugs are paid for by Medicare, and both drugs are an open-ended treatment protocol. And what I mean by that is that we can't treat this with a single injection, nor can we treat this with a single series of injections. But what treatment with both drugs entail is treating initially for 1 or 2 or 3 injections and then following patients carefully. Most patients will need some sort of ongoing therapy over a matter of years. The interval may be once a month, it may be once every 2 months, it may be once every 3 months. Occasionally, we do get home runs where somebody gets 2 or 3 injections and they're done forever. But most typically, this is an ongoing process.